So I'd like now to introduce our next speakers um, and present our next speakers representing New York State AIDS Institute, Joanne Morn and Kraig Pannell. So community members, please welcome Joanne Morn and Kraig. Are you guys there?
Hi, Antoine. It's Kraig. I'm here.
Yes. Hey, Kraig.
Good morning, everyone. I do apologize. Joanne Moore has been pulled into a number of different priorities and is unable to attend today. But she wanted me to extend her greetings on her behalf. We continue to be proud sponsors of the In My Mind conference, and we share in the mission and vision of Antoine and the organizers of this conference. We know that it's important to highlight the issues that that are that disproportionately impact LGBT people of color across New York State and around the world. We have maintained a mission within the AIDS Institute to look at health disparities, to look at how we can overcome them, to take a more um, a positive lens and looking and not looking from a deficit base. We also continue to look to community for our responses to the current pandemic and the HIV/AIDS epidemic that we've been experiencing for quite some time. We encourage your feedback. We encourage your partnership. We could not do this work alone. The AIDS Institute has been from the beginning a part of the COVID response. We have a number of staff who are deployed, lending our expertise that we have learned through handling epidemics to New York State, and we have them deployed across the state assisting within that work. We have a number of folks within their regional communities also reviewing school plans and looking at ways to contribute within those regional offices. So it's not just based out of our New York City office or our Albany office, but our regional offices are intimately involved as well. Joanne and other state directors of other agencies are completely involved in response to this. And there's a lot of work yet to be done, but we stay informed and they keep us and the staff informed. As you all may know, that we all are working remotely, but as you can see, I'm in the office today because Albany has no internet, or where I live in Albany has no internet rather. So I had to come in, but it's a pleasure to be with you all today. Joanne Moore, in response to a lot of the things that have been going on within our communities, the violence, the injustices that we've seen, and some of the things that Antoine has touched on when he was talking with Commissioner Smith, the AIDS Institute and Joanne Moore have made a mandate to make sure that we have a commitment to health equity, and we also have a commitment to diversity and inclusion, not only within the AIDS Institute itself, but also within the providers that we fund and within the communities that we work in. This is a mandate that, we at the AIDS Institute take seriously, and that Joanne takes seriously and has adopted. Within the AIDS Institute, we also have a health equity committee that has been continuing to go on for quite some time, and their mission and vision has been adopted by Joanne and shared with the remainder of the AIDS Institute. So we continue to do that work. We are continuing to work with community to drive the mission of the AIDS Institute. As you all know, we have the Ending the Epidemic Blueprint, which was established by the governor and adopted by the governor and we're supposed to end the epidemic by the end of 2020. We will not have the data about how we have done that and what that looks like until the end of 2021 when the data comes out. But we are still on target with that. There have been a number of listening sessions that have taken place across the state that I may mention further in my presentation, that where we have spoken with regional groups and population groups about where we stand and best ways to move this work forward during 2020. Again, on behalf of Joanne, she wants to share her appreciation and gratitude for the planners of this conference, for the work that Antoine does on a consistent basis, keeping us in the know and in keeping the mission of this conference and his organization in the forefront of our minds and keeping us abreast of what's going on. So thanks again, and those are words on behalf of Joanne Moore. As Antoine said, I am, as you can tell, I'm not Joanne Moore. I am Kraig Pannell. I am the director of the Office of LGBTQ Services here at the AIDS Institute. I will attempt to share my screen to go through my presentation, which will be an update around some of the things that we're working on here at the AIDS Institute and what you can see in your communities. Can everyone see the slide? Okay, thank you.
Yeah, we can see it.
So the presentation is around prioritizing community, the AIDS Institute, and the LGBTQ community. Some concepts to consider that we take into consideration when looking and working with working with communities, and especially during this time. One of the main concepts that we take into account is looking at the hierarchy of need. Abraham Maslow stated that people are motivated to achieve certain needs and that some needs take precedent over others. Our most basic needs are for physical survival, and this will be the first thing that motivates our behavior. Once that level is fulfilled, the next level is what motivates us, and so on. So, a lot of times when we talk about um, how do we respond to communities and what are their hierarchy of needs? So a part of that conversation needs to be what is their hierarchy of need versus their perception of risk, and what is their perception of protection. So in looking at Maslow's hierarchy of need, you're talking about, you know, the physiological needs, their biological requirements for human survival, for food, drink, shelter, clothing, their safety needs. Once an individual's physiological needs are satisfied, the needs for security and safety become salient. People want to experience order, predictability, and control in their lives. These needs can be fulfilled by family and society, whether it be school, businesses, medical care. The next level is love and belongingness. After psychological and safety needs are fulfilled, the third level of human need is social and involves feelings of belonging. The needs of interpersonal relationships motivates behavior. For example, friendships, intimacy, trust, and acceptance, receiving and giving affection and love, a, a feeling of a part affiliated with something, being a part of a group, whether it's family, friends, or work. The fourth level is esteem, where it's classified in two categories: esteem for oneself, such as dignity, achievement, and mastery. And then there's also dignity, um, the desire for a reputation and experiences and respect from others. And one of the final stages is self-actualization, where this is the highest level during the hierarchy and referred to the realization of a person's potential, self-fulfillment, seeking personal growth and peak experiences. And as I mentioned before, we have to consider people's perception of risk not along with their hierarchy of need. The perception of risk is around an individual judgment, an intellectual and internalized assessment of themselves, an assessment of the risk, and the emotions and feelings regarding those risks. Perception of risk is important because it determines which hazards people care about and how they deal with them. Risk perception has two main dimensions: the cognitive dimension, which relates to how people know and understand the risk, and the emotional dimension, which relates to how people feel about them. And as I said before, you have these two concepts, whether it's the perception of risk or the hierarchy of need, which influences people's behavior and choices around things. For some individuals, their hierarchy of need is greater than their perception of risk. Therefore, an individual may engage in behaviors that they know are high risk in order to meet the need that they're experiencing. For example, an individual that is seeking safety may engage in behavior that places them at increased risk for HIV, STD, hepatitis C, despite the fact that the perception of risk for that behavior is high. Their need for safety is greater than their need for the than their perception of the risk that they're being exposed to. Consequently, they engage in a behavior that places them in risk in order to meet the need for safety. there are risk and protective factors at many levels that people have within their environments. There's the individual, the interpersonal, institutional or organizational, community, and policy. The individual includes factors that have to do with the person's psychological state and physical capacities, such as intellectual and physical ability, knowledge, values, emotions, and health. Interpersonal includes factors in relationships, such as spousal relationships, sexual partner, family, friends, peers, such as rewards and consequences that may protect the individual from engaging in risk-taking behaviors or motivate risk-taking behaviors as well. The institutional or organizational, within a work setting or an organization, there are factors such as organizational support, resources for healthy living, existing programs, policies within those organizations that encourage people to engage in healthy behaviors and restrict them from, and then there's also maybe policies that also restrict them from engaging in those behaviors. The community, which includes areas such as the media, social networks, social acceptance, accessibility to goods and services. Those elements can interact to encourage people to protect themselves or provide a barrier to healthy behaviors. And then there's also, lastly but not least, there's policy. Within countries, state and local communities, there are laws and regulations that encourage healthy behaviors, and those that make responsible decisions making difficult. Those that make decision making difficult, which lead to taking risk behaviors. So these are the risk and protective factors that we have within communities and populations, in the hierarchy of need and the perception of risk. All of those things work together for people to make decisions. And a lot of times, we sit in our offices and we write requests for applications and we review pieces, but all of those elements are important to us and that's why we go back to community in order to understand what's going on. What we may view from where we sit, or what I like to say, the quote unquote mile high view, what is a protective factor in a community may seem to us as a risk factor, but community members and the communication with community and the populations that we're working with let us know that no, this particular store, this particular place of worship, this particular not government funded entity within our neighborhood is crucial for us to be able to have these protective factors, for us to be able to gain knowledge or have access to healthcare or access to information. So it's important for us to be able to know what those are so we can support those community efforts as well. It is that is why we engage the community throughout our processes as we move forward in the work. So as I mentioned previously, I talked about the ending the epidemic and beyond. We have the partnerships that we've created where we did the listening sessions around the state. We know that we could not do it without community partnership. We focus on health equity, we focus on sexual health, and we go back to the community to find out what that means and what are those definitions and what does it look like for you within your environment. So that way we can implement this with fidelity, and not only implement the plan with fidelity, but also implement the plan in a way that is understandable, reasonable, and respectable for the populations it's supposed to address. And we know that this plan is not the same in every region. What works in Albany may not work in Staten Island. What works in Buffalo may not work within the Bronx. But we want to make sure that there is an individualized response, a respectful and responsive response, and that therefore we can include the community within those conversations. As I said before, we must continue the work to end the epidemic by the end of 2020. There are goals and planning pieces that are in place. I talked about the over 20 virtual sessions that have taken place. We've also held sessions within other state agencies. We know that the work that is outlined in the blueprint and in the recommendations from other agencies across the state, other areas across the state, The AIDS Institute is the champion of the blueprint. We also acknowledge and recognize that a lot of this work does not happen in a silo, and that we need to pull in and engage in work with our other state partners. As Commissioner Smith mentioned, there is an interagency task force on HIV and AIDS, where all of the agencies come together to talk, state agencies come together to talk about the work that they're doing, what we're seeing at the AIDS Institute, and how to best move this work forward. We also have an interagency on LGBT task force as well to look at LGBTQ health and human services and what that looks like and what other state agencies are implementing to make sure that, one, to ensure that there's alignment and to ensure that that organizations and the other state agencies have the information they need in order to make the appropriate decisions. The AIDS Institute itself has a number of initiatives specifically for LGBT and LGBTQ individuals in New York State. We have the Health and Human Services Initiative, which falls under the Office of LGBTQ Health Services. This is an initiative that has been a part of AIDS Institute since 2008, was established many years prior, prior to coming into the AIDS Institute, but the AIDS Institute took it on and wanted to provide it with some infrastructure and sharing because of the fact that the AIDS Institute had a number of relationships with existing organizations. There was an RFA that went out last year regarding high impact prevention with communities of color. And with emphasis on the HIV prevention and services for transgender and gender nonconforming individuals, with an emphasis on communities of color. And then we also, through our healthcare services department, we have a transgender healthcare services contract that was 4 awards were made to transgender healthcare agencies across New York State in order to provide culturally responsive and appropriate healthcare. As I mentioned before, the LGBT Health and Human Services Initiative is to provide and develop or enhance comprehensive health and human services for lesbian, gay, bisexual, and transgender individuals, their families, and communities through the implementation of strategies and innovative interventions. This is an RFA where we provide the framework, but we allow the organizations to write in what is important to them and what they want to work on within their particular institution, within their particular communities. So we do not prescribe how they provide the services, but we do let them know what outcomes we would like to see, as with regard to access to healthcare, improvement in health outcomes, and things of that nature. As I mentioned, the initiative aims to address the key social determinants of health impacting LGBTQ communities: economic stability, education, social and community factors, health and healthcare, and the neighborhood and environmental factors. Going back into what are the hierarchy of needs and what are the risk and protective factors within those communities, and having those agencies tell us how they want to be responsive within their particular regions and within the particular age group that they're looking at. We fund 38 organizations across the state that provide services anywhere from across the lifespan, and dependent upon, we have some legal programs that we provide we fund services for as well. The High Impact Prevention for Communities of Color initiative, which is just now beginning to enter its 2nd year. The funding supports the provision of client recruitment and engagement in HIV prevention, community collaboration, condom promotion, education and distribution, direct provision of HIV testing, direct provision of documented referral to STD and HIV screening, linkage and navigation services, which some of you may think of as more of a contract management or case management kind of piece. And we have prevention and supportive services along with that. The transgender healthcare services, as I mentioned, there are 4 places that are funded throughout New York State to provide funded to meet the complex medical needs and the essential elements necessary to provide culturally responsive healthcare for transgender individuals. The 4 entities involved and funded by that particular initiative are Community Healthcare Network, Community Health Project at Callan Lord, the Research Foundation of SUNY Downstate Medical Center, and Evergreen Health Services in Western New York. The program support increased outreach to engage transgender and adolescents, adults who are not connected to ongoing care, and to provide HIV, hepatitis C, and STD testing and other healthcare services in a transgender setting and link those to care. The programs must be accessible to transgender individuals during the time frame that they deem necessary, and to ensure a continuum of services that are needed by the population. The program design requires enhanced non-traditional work hours, mobile outreach, and use of peers and inclusive social networks. Some of the updates around emerging efforts within the AIDS Institute. We previously had an internal transgender and gender nonconforming health work group that was comprised of staff from different areas of the AIDS Institute. We are looking at reconstituting that and beginning to do work across the agency to see how our work is reflected, and it's not just housed in one place, and that making sure that we are offering responsive services. We do have in looking at employment practices, previously we had 2 consultants of transgender and gender nonconforming experiences. Currently, we do have 1 consultant who is still working with us and continues to help the AIDS Institute with its internal processes and being culturally responsive and aware of the needs of the transgender and gender nonconforming communities, but then also making sure that we're implementing what their implementation strategies and recommendations were. We do have a statewide LGBT health and human services needs assessment that we do every 5 years that is currently taking place. The first wave of that needs assessment were focus groups that were done just at the beginning of COVID, and they were virtual focus groups. There are currently some other focus groups that are population. The initial phase was with service providers regarding LGBT health and human services needs. The second phase, which is currently ongoing, there are virtual focus groups that are happening with specific populations that represent the full spectrum of the LGBTQ community around that needs assessment. And the third phase will be when the needs assessment is actually developed, and then we will submit that. We will turn that out. The survey will go out hopefully at the end of next fall or the end of next spring. We will have that in a virtual format. We will have it in a online format and paper, and we will get that out. We also have continued over the past couple of years what we term our transgender, gender nonconforming, non-binary leadership collective. There were a group of transgender and gender nonconforming individuals that approached the AIDS Institute stating that there were some things that they wanted to address within a forum that is safe for TGNC and NB individuals. And there were leadership pieces that needed to be addressed, and there were also elements around conversations that they needed to have amongst themselves. So we've had 2 formal leadership collectives, and we've had some subsequent smaller ones with specific populations, all led by TGNC and non-binary individuals. Not only led by them, but helped to be designed by them as well. As Commissioner Smith mentioned, in New York State, we have had the passage of Gender Expression and Non-Discrimination Act. We work closely with his office and the Division of Human Rights to make sure that there is information that is going out to our providers and into the community in a language that they can understand. Oftentimes we write legislation or we write brochures and information to go out to communities, which are very important and vital to them, but it's not written in a language that they can internalize, understand, or even be able to relate back out into other populations that need that. So we've been working closely with them on their listening tour and making sure that information is going out. There are also the healthcare protections that were implemented by the governor and the Department of Financial Services, which issued a circular advising issuers that they must cover all medically necessary treatment for gender dysphoria, cover infertility treatment regardless of sexual orientation or marital status, cover PrEP for the prevention of HIV infection, and then issuers may not deny any claims based because of gender or the individual does not match the gender of someone whom those services would originally be typically be provided. So this is information regarding the contact information from the New York State Division of Human Rights. They have also put out an LGBTQ handbook. The New York State Division of Human Rights has excuse me, their researchers or their people on tap to be able to research whether or not if what you're experiencing actually is discrimination. So if anyone feels that they have been discriminated against based upon sexual orientation, gender identity, um, excuse me, or any other matter, you can contact the New York State Division of Human Rights, and they will work with you on that. You also see a link to their LGBTQ handbook that they put out during Pride Month, which has a listing of a lot of the work that they do, how to access that work, and the number of protections for LGBTQ individuals within New York State. One of the things that we've been working on through the Office of LGBTQ Services is sexual orientation and gender identity data collection. We have had some success with that in the AIDS Institute. And a part of that process, as you can see, was our internal work group, our external work group, our consultants, and the HIV advisory body, and taking information back out into the communities to see what we should be doing. A little over a year ago, the AIDS Institute has instituted the new terms that I will share with you. The former list included sex assigned at birth, male, female, declined to answer. Um, the current gender identity listed as those 4 categories, and sexual orientation. The new listing looks like this. We have expanded all of the categories that we collect within our AIDS Institute data collection system. We have added in queer, pansexual, asexual, not sure, questioning, chose not to respond. And then there's also a drop down box that we included for terminology changes all the time. And terminology is different amongst different communities. So we wanted to be inclusive and be aware. So we have a drop down write-in box that is there. We also asked the person's current gender identity. It was intentional to list women girl first and trans women and girl first as members within the AIDS Institute and Planning Committee said misogyny is real, and we wanted to acknowledge that, and we wanted to make sure that women and transgender women were giving their appropriate space within our data collection system. We also added girl and boy in there in order to reflect the younger populations that are there and to have it be more representative. You will also see that we included non-binary, gender non-conforming person, not sure, questioning, and another drop-down box that would enable folks to write in with what their current gender identity is. And we also added in sex assigned at birth. So it was a 2-step question regarding gender identity, what your current gender identity is and what your sex assigned at birth was. We know that gender identity is fluid, and we wanted to make sure that ensure that we captured the way that people really want to be self-identified. And we've added in the category of intersex as well within our data collection. As I mentioned previously, every 5 years we do an LGBT Health and Human Services needs assessment. This is a link to the previous needs assessment, which was done in 2015, which was conducted by Strength in Numbers. There were 20 focus groups that were done. There were expert stakeholders, and we had almost 4,000 respondents from June 2015 to August 2015. The key findings in the report were addressed issues of health status and access to health care, barriers to care, survival needs, and access to public benefits, PrEP, and disparities across the life course. There were also additional questions for individuals who identified as being of trans experience so that they could address some additional questions if they would like. As a result of those questions being asked, we were able to issue a secondary report, which was the Transgender Economic Disparity Report that is out as well, that lists some of the key issues around health disparities and the needs of transgender New Yorkers in New York State. As I mentioned before, TRX Development Solutions is implementing our current needs assessment, and we hope to have the survey out to everyone by the end of the spring of next year, and hopefully we can repeat or better the success that we had in 2015. There will also be questions in there that will be incorporated around COVID-19 and the data response to that, and the response from organization or individual and organizational responses to those questions as well. And again, I'm Kraig Pannell, the Director of the Office of LGBTQ Services, based out of the Division of HIV, STD, Hepatitis C Prevention with the New York State Department of Health AIDS Institute. Thank you.
Thank you very much, Kraig. I just had to try and for a quick minute to to move my cursor and and to find a microphone. I have one question. Is when I listened to what you were talking about just now, I heard actually two questions. The first question that comes to mind is, how does the AIDS Institute respond to the current US administration's LGBT policy when we want to consider that the LGBT policy from the current US administration will impact HIV funding? And how is that going to impact the AIDS Institute's work and for LGBT, not just people of color, but LGBT within the state? That's one. The second question that I want to throw at you is, I heard you talking just now about equity and inclusivity and about sensitivity to many different communities. How is the AIDS Institute utilizing its office to incorporate cultural sensitivity in the way that it interacts with LGBT people of color communities as a way to be able to reach more LGBT people of color, but as a way to reach them where they are rather than using a white-oriented kind of model or paradigm? So there are two specific questions.
So with regard to the AIDS Institute response based upon the federal mandate, right now, Joanne would be better to answer more around the specifics around that. But to my understanding and the information that I have, New York State, we are proceeding as we always have been, that the Ending the Epidemic Blueprint is our priority, and that's what we are working from. That is a community-originated document. That is the charge that was adopted by the governor that we are following through on. And we have that commitment to the listening sessions, that over 20 listening sessions that we did with community members in order to continue to move that work forward. There are I'm not sure of the resource allocation because I haven't seen the budget, but we do continue our commitment that we have. We have re-engaged with our other state agencies around portions of the blueprint where it may fall more squarely under their lead, and trying to identify what they are doing. Engaging in conversations with Commissioner Smith, with other state agencies, whether it's the Center for Community Health, the Department of Labor, things of that nature, to ensure what can you do in order to help make this lift and make this a reality. We will champion it, but we can also begin to have conversations around implementation strategies and recommendations that you have. We have those recommendations from community members. Internally, we are continually raising awareness. We have our we bring in folks from the community to talk about with other state agencies about what they can do and what they should be doing. We have the HIV advisory body, which guides our work, which is with representation from across the state. So we are doing the best that we can to ensure that there is not necessarily a negative impact on the work that we're doing. We're remaining completely aware. We have staff members who sit on a number of national committees and national organizations to remain in the know. And we are as strategic as we can be and have conversations internally about what's the best way to move the continued work of the AIDS Institute forward and meet its mission. With regards to health equity, As I mentioned, we do have a health equity committee that has been formed. The Health Equity Committee has created its own charge, its own mission, its own its own goals, which Joanne has adopted and has shared AIDS Institute wide and made very clear that this is what our priorities are around health equity within the AIDS Institute. The Health Equity Committee that meets on a monthly basis has representation from every department and every office and every division of the AIDS Institute that sits on the steering committee. There are other subcommittees that are represented by all of the AIDS Institute. It is the expectation that as we move forward with health equity, that these are the elements and definitions that we are working from within the AIDS Institute, that these are the what we are being held responsible for, not only with our inward facing actions and our inward facing documents, but also with our public facing documents and any subsequent requests for applications and things of that nature that go outward. We have a series of trainings have been developed and implemented within the AIDS Institute. Joanne has signed off on all staff receiving health equity training, not only internally, not only from internal staff, but also bringing in consultants from outside to make sure that we have what we need. There have been assessments that have been, there has been an internal environmental scan that has been done around health equity and where we sit as AIDS Institute staff and what our needs are with regard to growth and professional development around in our understanding of health equity. Um, there are a number of other trainings in leadership development pieces that are being implemented, all at the behest of division directors and with the stamp and seal of approval of Joanne to continue to move forward to make sure that the ACE Institute is as representative of our mission, is as representative of the population that we have. If there are empty seats, that if there are seats at the table that are not filled by uh, people that we need to have at the table, to have a voice at the table and to be heard at the table, we are encouraged to bring those folks along and to encourage those folks to participate in whatever way possible. So that's how right now we're looking at health equity. We do have Louise Square, who is our director of health equity here at the AIDS Institute. She has a background in health equity work outside of AI and has taken this charge on over the past year. And our health equity committee works with Louise in order to implement the work that needs to be done regarding that matter. And I apologize, I forgot your second question, or did I combine the two and answer them?
In a sense, you kind of, but not quite, because the second question was, how is the AIDS Institute incorporating cultural sensitivity in and among LGBT communities, particularly LGBT people of color? So it's meeting them where they are in their how they represent culturally being LGBT or even with HIV. So there is the African community, there is the West Indian community, there is the Indian community, there is a Central American, the Dominican, Puerto Rican, or even South American communities, or even the Native American communities. How is the AIDS Institute incorporating cultural sensitivity as a way to meet them to impact or to promote or direct HIV work, including mental health?
And the majority of that comes from the community. We reach out to organizations that we are aware of that represent those various communities, not only organizations that we fund. We have, we do fund organizations that serve those particular and specific communities, but we also have we bring folks in and we want to hear their voices about what's the best way for us to communicate. How do we utilize your voice in doing that? There are a number of social marketing campaigns that we engage in where we bring in those community individuals. There's the HIV advisory body where we try to ensure that we have representation from a number of those populations and communities. And if we recognize that there is not a seat at the table, making sure that we go out and we find those individuals, like what does this look like? What does this information look like going out in if we know we have a large Cuban population in Western New York, what does that information look like, and who do we pull in to have that conversation, and who are those community stakeholders that we can be able to do that.
Good. Are you, I mean, that's good, because I think it's important to try to bring in other people. And this is a conversation I've been trying to also have at the OMH, is about bringing in people from the communities with specific cultural backgrounds to be able to work towards providing for them. So thank you very much.
As I mentioned, it's important that we also hear the voices of the community coming to us. We can reach into the community, but also sometimes we may be reaching into those known individuals and tapping that same well at all the time, who may not have all of the inroads that we believe that they have. So I think it's important for anyone that is on here who lives, works, has family in New York State, has recommendations around, best ways to reach specific populations, to let us know what they are. If you are interested in being included in some of those elements, please let us know. So that way, when we go back into those communities, or when we're targeting, or not necessarily targeting, but prioritizing those populations to be able to do the work and wanting to encourage them and support them in the work that they're doing, there may be work that's indigenous to communities already that are going on that we can support in some way, as opposed to us coming in and putting something in there that is counterintuitive. So so that we are not continually tapping the same well, and that we have fresh information, and that we have new people coming to the table, so that we have a wealth of ideas that are there. I encourage, those of you who are participating today, or those of you who know other individuals, to let us know who those folks are and to bring them in, and so that we can take them under advisement and consideration. And when we send things out, here, what are your thoughts? What are your reflections? So that we can be as culturally responsive as we can within particular regions and within specific communities.
Thank you very much, Kraig. We are almost out of time for you, but I have a comment here from someone. I think communities are looking for opportunities beyond being heard, but seeking outcomes of accountability that reflect the change that should be focused upon or in those conversations. This seems really important, given that the representation of community at the table has limitations in its representatives. What are those outcomes? We may not be able to answer that question now, because we have to move on to the next section for the breakout. But that may be a question that can be asked within one of the breakouts. The person who's asked that question, Corey, I don't know if you're going to be in which breakout you're chosen. You're chosen, so maybe you might be able to ask that question there. So Kraig.
Unfortunately, I'm not going to be able to be a part of the breakout, just due to
No,
the
that's
fact
fine.
that I have no power and internet at my home that I need to go tend to.
Okay.
But you all have my contact information. Feel free to email me that question.
Yeah.
And I will get back either to you, Antoine, for you to share with everybody else, or Corey can email me directly, and we can continue that dialogue and move that forward. I wish you continued success with this conference. And you all can please feel free to let me type my email in this chat room, because folks are sending questions that I can't get to right now. But
okay. All right. So thank you very much, Kraig, and we're looking forward to being in touch with you.
Thank you all very much.
Thank you.